Hi everyone, and welcome to Anaesthesia Coffee Break. I'm Lahiru. So yeah, we have a special live episode in conjunction with Adrenaline Memories. So just if you're not aware, Adrenaline Memories is something that Stan's doing kind of once a week shoots. You can sign up. I'll put the Patreon link, and it's just really great tutorials about everything for the primary exams, so physiology, pharmacology, everything that you might need to know. So yeah, check it out in the link that I'll put in the story notes. But yeah, Stan, let's get started.
Well, before that, I think you need to tell us, where have you been for the last 3 months? Because I think it's been 3 months since our last episode.
Yep. So if you don't want to hear this, please skip forward, because I'm always aware that maybe we ramble on a bit at the start. So I've been away in Broome for 5 months, and just working on some education stuff with the DRGA, which is like the new diploma for GP anaesthetists, and it's been great because I just get to work on education stuff kind of full time, which is a bit of the dream. But I actually do miss clinical anesthesia. I feel like, if you're not doing clinical stuff, or if you're not doing the stuff and you're teaching it, I'd feel pretty disconnected. So I'm pretty excited to get back to work next month.
You've done some amazing stuff, and for those who don't know, Lahiru runs the Anaesthesia Coffee Break and the Instagram page, ABCs of Anaesthesia. If you haven't followed that yet, do follow it, because you put up videos which are actually very relevant to, I think, introductory training, as well as part 2 as well, which you do a lot of teaching for. Is that right?
Yeah, pretty much anything that's not primary, I'll try to, I'm kidding. So I've managed to get someone to cut down my videos to make them in bite-sized chunks. So I'm just posting those regularly, and hopefully they're useful. It's a new space. Like I struggle to know what's going to be useful and what's not, but it's a bit of an experiment to see which things are useful and which things aren't. So yeah, like everything, just keep on learning.
Absolutely. I mean, you are going leaps and bounds in this space. I'm still waiting on the background to see that YouTube award. When you reach a number of subscribers, they give you like that little award which everyone hangs up in the back in the plaque.
Yeah, is that so? Is that the goal? Is that the?
We got to get you to go viral. Got to get you to go viral. Anyway, all right, we better get started.
Okay, let's do this.
Okay, so the question that we're going to run through today is with regards to the onset of neuromuscular blocking drugs, and it's from 2004, question 2, the first paper. And the question is, outline the factors determining speed of onset of neuromuscular blocking agents. Now, Lahiru, how would you go about structuring or even classifying this answer?
Yeah, so I feel like with this question, it's obviously really broad. Like there's just so many factors that could affect speed of onset. So I feel like I've really got to come up with a category, and I keep mentioning categories all the time whenever I mention an answer, because broad questions require broad categories and your ability to not miss things, especially in this exam. So the way I thought about this, so I don't miss anything, is to think of physicochemical things, pharmacokinetic things, pharmacodynamic things, and then patient things, which are kind of linked with pharmacodynamic, but let's just put it in a separate category. So I've got those 4 categories, and I'm just going to literally, if I'm thinking of the short answer question, I'm probably going to write one on each page or one on each half page to give me lots of space to fill those in as I go through in that 10 minutes. But I'm also thinking about Fick's law of diffusion, and why, while you don't just want to, regurgitate Fick's law of diffusion, or the rate or the speed of onset is area on thickness times solubility over the square root of molecular weight times the concentration difference. Like there's only so, you really have to link that back to this structure. But I think I'll just put that there so I don't forget to write anything under my headings that I've already created.
And I think that's a really good way to think about a very broad answer like outline. So whenever a question says outline, I think it's really good to have really key structures or key subheadings, which you have listed. So physical, chemical, pharmacokinetics, pharmacodynamics, patient factors. And I think in somewhere around those areas, probably in the kinetic section, I think you can put in Fick's law of diffusion. I guess it's really interesting because before we sort of go into detail into each of those subheadings, I think clinically, for us, when we think about onset of neuromuscular blockades in clinical scenarios, those are probably the main ones I sort of quickly go through to think about how I can quicken the onset of neuromuscular blockades? I mean, scenarios that you can think of where you would want to have rapid action of neuromuscular blockade, what would they be?
Yeah, I mean, really, I just want for a rapid sequence induction of any sort, or anytime actually two reasons: rapid sequence induction where there's an aspiration risk, and then if I've got a difficult airway, because I just want to get bag masking, everything optimized, so I'd give a fast paralytic agent. But then also in, standard my favorite procedure, ECT, where you just need a fast onset, fast offset relaxant. So that's an in-joke here. So yeah, for those reasons, I want fast onset. I gotta say, Stan, like I do feel like a lot of this is academic, because as we go through these things, I feel like the choice of relaxant being succinylmethonium or rocuronium and those properties of it are the biggest difference. Whereas I'll mention differences like, if I give it in a proximal vein, like it'll be faster onset than a peripheral vein. And I get that that is a real thing if you inject from the foot versus from a central line. But if I'm injecting from the hand or the forearm, that's really just not the most tangible. It's not that it's such a small difference compared to the difference between sux and cisatracurium.
Yep.
If I'm going to use sux or big dose, right? Yep, go on.
You say that now, right? But but I promise you, after today, after you've gone through your list and you do your next list, you'll be like, right, I talked about all this, and now this makes sense. Because I can tell you, there is an appreciable difference, as you said, when you inject it through a central line versus injecting it on a foot. Like I've done it.
I agree with that.
Yeah, I've done it on a foot before. You're going, what is wrong? Has it tissued on the foot? Because it has to go all the way from the foot back into the heart, and then after that recirculate systemically. So you think about the distance traveled versus injecting it straight into the central vein, into the internal jugular, right into the right atrium, right ventricle.
Yeah, absolutely. But again, if you have a fast flowing drip and you're pumping it, the difference between the hand and the forearm, it's nothing, right? But
good point.
I take your point.
No, good point. And that's, I think it's a really good important point, that when you do give muscle relaxants to quicken the onset, you proceed it with either a quick flowing drip or you give it a really good flush. But I think we'll talk about the factors now, and that way it'll be a lot more relevant, because I do think about some of them. And you're right, there is a lot which is probably academic, but I must admit, I do think about a lot of them, especially when I think about onset of neuromuscular blocking and how to quicken those that effect. And, things like priming. I must admit, we'll have to chat about that, actually, whether you do priming or not. Okay.
Absolutely.
So tell us about physicochemical.
Yeah. So, I mean, really, this is the I guess, properties of the molecule itself. So if I'm thinking of fixed law of diffusion, the molecular weight will be the thing that stands out between muscle relaxants. Almost invariably, they're not very soluble. They're uniformly not very soluble. So molecular weight, the lower the molecular weight, the faster the substance would probably diffuse. Again, I don't really think about this practically. I just give the fast acting agent. But this is for a complete answer. I've also put in here that depolarizing blockers like sux have a more rapid onset than non-depolarizing blockers, most of the time. And I'm pretty sure there was, so essentially, because of the action that is depolarizing, it will be a faster onset than something that antagonizes a receptor. But I'm pretty sure back in final exam study, this is years ago now, there was a study that showed that 1.2 milligrams per kilogram of rocuronium was, statistically significantly, but probably not clinically significantly faster, like fractions of a second faster than sux or something like that. So, with enough dose, you can overcome this physicochemical property or the action of the drug.
Look, I think from the sort of the numbers quoted from the books, you would say that the onset of action of succinylmethonium happens within 30 seconds for the average patient. I think that's pretty much agreed. With rocuronium, I think that with the study sort of you mentioned, you would say 30 to 60 seconds. But I think that it's not a consistent effect, if that makes sense. I think there are certain scenarios where you can create it within 30 seconds, but more often than not, I think 60 seconds is probably a safe number to sort of use. But you're right. I think there was that study which showed that you can get a very, very similar onset of effect. Now, I think what's interesting with your introduction with physicochemical is that you've introduced the idea of molecular weight into your answer. And molecular weight fits into what you talked about before with Fick's law of diffusion. And because you've done that, I'm sort of thinking, if I was to structure this answer, I would actually probably have Fick's law of diffusion after those 4 things that you've listed, or maybe somewhere in the introduction, just so that it frames the answer. It ties in all those ideas together.
Yeah, correct. That's exactly what I'd do.
Yeah, good stuff. I mean, this, with the creation of answers, it's all about connection. It's all about connecting ideas together. We'll talk about this later, but I've been playing a bit of chess, and it's all about sort of linking sort of different ideas, different concepts, and just bringing it all together towards the end. I still can't beat you, but
Stan, chess is life. We know that. That's good.
All right, now the second bit. Tell us about how you go about answering the pharmacokinetic subheadings.
So first of all, pharmacokinetics is always ADME, so absorption, distribution, metabolism, and excretion or elimination. And so the things that are probably most relevant to that for the onset are going to be the A and D parts of that, so absorption and distribution. And this is kind of the logical stuff. So if your route of administration is intramuscular, like intramuscular sucks, that's going to be slower than IV. And if you've ever had, a kid without a trip laryngospasm during inhalational induction, and you've had to give sucks IM, you know how painfully slow that is while the sats are falling. So, from first experience, that obviously IM is going to be slower than IV. And also other things like, the vascularity of the site. Veins obviously vascular, but, if you're injecting it into a very low vascularity muscle group, then it's not going to be fast onset. You could also think about the site of injection. So, like we mentioned before, is it in the foot or is it in a central vein? That would definitely make a difference with that kind of distance, because literally it's a time for those molecules to get up to the heart, be pumped from the heart to the muscles, and then exert their action. So you've got that real variable time of, arm to brain circulation or foot to brain circulation time. You can also think about just the rate of injection. Like, are you giving it fast, or are you doing that really kind of when you're a junior, you're so careful about what you're giving that you do things really slowly, which is the opposite of often what we would want in anesthesia. So yeah, location of injection, rate of injection, vascularity of the site if it's IM. And then, volume distribution. Now, again, this is probably not something I think about a lot, because again, I just choose the drug and I give the dose. But you can imagine these situations where someone's got to reduce volume of distribution, reduce muscle mass, or reduce plasma proteins, which means that there's going to be free drug, and maybe this would mean that there's more free drug to exert an effect, more of a concentration gradient from vasculature into the neuromuscular junction. And you can imagine these situations: elderly patients with low muscle mass, sick patients, liver disease, low albumin states. Neuromuscular blocking drugs aren't really highly plasma protein bound, but still, this is theoretically something that could be there.
I think it's a good point. So with volume of distribution, it really has to do with ultimately the dose that you give to deliver the concentration desired, because we know that the concentration equals the dose divided by your volume of distribution. And I think that's where that sort of concept sort of ties in. But I think you're sort of talking about in terms of the delivery of the drug to the effect site, which probably fits into more pharmacodynamics, which I think you'll go through next. Yes. But I think that's a really sort of good sort of ideas that you've sort of listed in terms of pharmacokinetics, where you talk about the route of administration, which is definitely important. And then after that, the volume of distribution as well. I think things like metabolism and elimination, probably less important, don't you think, for onset of neuromuscular blocking agents?
Exactly. I'm focusing on A and D with this. That's all onset stuff. Metabolism and elimination is really offset stuff.
Yeah.
So absolutely.
Okay. Now we'll move on to the next one, which is pharmacodynamics. How would you go about answering that one there?
Now, if anyone's listened to some of my talks with in the primary course or the final exam course, I always talk about broad questions and specific questions, and how if you do get a broad question, especially in the final exam, you really want to say, give a rough, broad answer, but quickly get to the point of difference. So when I think about all the all the factors that affect the onset, physicochemical, pharmacokinetic, pharmacodynamics, and patient, the physicochemical stuff, that's actually common to most drugs. Low molecular weights, diffuses faster, IV versus IM, volume distribution things. But the pharmacodynamics with this particular set of drugs is probably the most important point of difference. It's like you're not really getting this effect in your local anesthetics or in your IV induction agents. So let's get into it. So let's talk about two things: potency and priming principle. And these are very specific for muscle relaxants. So I feel like these are probably a couple of more important things to mention that you definitely don't want to miss out. So this is also one of those things where potency, it feels a little contradictory. The less potent a drug is, the more rapid the onset is, because you now need an increased dose, so therefore increased molecules to achieve the same effect. And whoever thought that a less potent drug would have an advantage? Like usually we think of high potency as a better thing. You need less drug. It's more economical, whatever. But with neuromuscular blocking drugs, in the example being rocuronium has an ED95 of 0.3, and vicuronium and the other drugs are often like 0.15 or 0.1 or something like that, or 0.2. And so rocuronium, you need more of the drug to get to that 2 times, 3 times ED95 dose. Therefore, there's more molecules. Therefore, according to similar Fick's law of diffusion, more molecules, more concentration will have a more rapid onset. So that's really the interesting part about this to me, the fact that lower potency equals faster onset.
I mean, that's a really good point, because I think if we apply that idea to another group of drugs, for example, opioids, there is so much there that doesn't actually happen. So you think about morphine, which is a less potent drug than fentanyl. And in this scenario here, morphine has a much slower action compared to fentanyl. So, that concept doesn't actually work there. And then you have to actually explore that, all right, why is it that this applies here, but this doesn't apply elsewhere? And go on.
And you can probably relate it straight back to Fick's law of diffusion and other factors, because suddenly with opioids, you have a pKa difference, which is substantial. So the point of difference with opioids is pKa, and maybe to a lesser extent lipid solubility as well. But suddenly you have alfentanil pKa 6.5 versus morphine pKa 8.1 or 8.9 or whatever it is now.
It hasn't changed since you studied it.
Yeah, that's right.
It's still around 8. Yeah,
totally. I remember 2 pKas: remifentanil and alfentanil. That's it.
Yes.
Anyway,
no, exactly right. And I think that's the key message across, is that yes, potency is one factor, but you also have to think about the other things like pKa and also lipid solubility as well. So those are the things that will actually allow you to actually understand this answer better. Good stuff.
Yeah. Now,
all right. And so with the potency, anything more to add to that?
Anything more to add to that? I mean, I feel like in common language, people confuse potency with efficacy a lot. So that's probably something just to, if someone's new to the kind of pharmacodynamics space, potency really is how much of a drug can exert an effect, whereas efficacy is the maximum effect of a drug. So a very potent drug might have less efficacy than another drug. So really potency, except for this very specific circumstance where it really does affect speed of onset, potency really is just it's just a packaging problem. If you have a really low potency drug and you need to give liters of it, that's a problem for dose delivery, right? It's a pharmaceutical problem. The other example I can think where it's a real problem is carfentanil. And carfentanil is just one of the synthetic opioids that's used in the zoo, essentially, so for large mammals. And it is so high potency that and lipid soluble as well. If you get a little bit on your skin, it could absorb, and you could just be narcotized and apneic. So drugs like that need to be handled with a lot of care, but they're so potent that you're looking at micrograms causing apnea and narcosis and death. So
all right, we're going to explore we're going to have to do another episode of why you know so much about zoo drugs. All right, but
I don't like what you're implying.
that's an episode for another day. All right. So now, what else other than potency would you add into your pharmacodynamic subheadings?
Yeah, priming principle. So this is something that I just don't do practically. But it is, so priming principle is where you inject the patient with a sub-paralyzing dose of neuromuscular blocking drug about, say, 5 minutes prior to then injecting the paralyzing dose. So if you think about that, you've kind of saturated up to 70% of your receptors, or whatever the number, but the patient, you need like a critical mass of receptors to have a patient fully paralyzed. And so then you don't need as much dose acting as quick for the full paralysis to have effect. So imagine if I'm giving rocuronium at trying to do a rapid sequence induction, maybe I'd give, like, to give an ED95 dose, which is blocking 95% of the receptors in 50% of the population, I would think about a dose less than that as a priming dose. Give it some time, observe the patient, monitor them, make sure they don't have any problems, and then when ready, I'd give the full dose. Again, it's just not something I've seen anyone do in recent memory.
Yeah, I've done it before, and I've often done it in scenarios where I've used rocuronium, or preferentially chosen to use a non-depolarizing such as rocuronium, and I'll give such as a small dose, so 10 milligrams in a normal average adult patient, and just to see what the effect is, and that whether you actually get a quicker onset. Look, from my experience, it's probably not appreciable. I think that what I do instead is that I just use a much larger dose of rocuronium. And in doing that, I actually go sometimes even above the recommended dose of 1.2 milligrams per kilo for induction, so that it actually gets that onset a lot quicker. And the thing is, with regards to duration, I'm not sort of too fussed about that, because obviously I've made the decision in my mind that this operation will last a couple of hours, and there's always that ability to use Sugammadex in case that you got residual paralysis.
Yeah, that absolutely makes sense. Yeah. Do you feel like you get, maybe you answer this, do you feel like you get a faster onset with even more, or is there like there's probably a ceiling effect with this?
This is a really good question. I really do believe it has to do more with timing than to do with whether you start to use a priming dose or not, because I think what often happens is that when you do a sequential induction with a non-depolarizing muscle relaxant, there's obviously that fear that the patient may still be aware on the onset of the neuromuscular blockade. And what I often see sequentially is what people will do is they give the opioid or induction agent first. So they give the propofol, fentanyl, or either the fentanyl or the propofol, and then they would wait. They would wait until they would have signs that they've lost consciousness, so such as not ability to open their eyes, not ability to respond, before giving the non-depolarizing muscle relaxant or rocuronium or succinylcholine. Now, by doing that, if you think about that, you're actually waiting 30 seconds before you give the drug, which will then take another 30 to 60 seconds for that to work. So from induction, you've actually taken a minute to a minute and a half to induce. And I think that if you're actually confident in your doses and you have trust in your pharmacokinetics or the onset of propofol and fentanyl, that you would probably have a lot of confidence in terms of giving your muscle relaxant straight after your induction agent. Is that something that you do, or do you wait for clinical signs of loss of consciousness before giving the muscle relaxant?
Yeah, when I'm giving rocuronium, I always wait for the patient to have some level of decreased conscious state, because it's so painful in the vein. So often the patients will react if I imagine it's so acidic, and that's why. Yeah. I'm not super confident on that reason. But yeah, I would always wait for them to be have some level of loss of consciousness.
Agree. So for those who don't know, when you give rocuronium and the patient is still conscious, it is very, very painful. Especially if you give it through a peripheral vein in the hand. I think less so, obviously, in the cubital fossa or in the central line. And look, one of the things that I do is, if I do want to induce quickly, I will give a good dose of propofol. So perhaps, I might slightly overcompensate, and knowing the side effects, I will perhaps, depending on the pharmacodynamics, depending on the patient, depending how sick they are, use some metaraminol, use some vasopressors just to counteract the larger dose of propofol. And by doing that, I become more confident that it's going to have the onset pretty quick, right?
And you're giving,
and I'm giving my rock probably
patient...
about 5 seconds after I give my propofol. Just with the,
good. Okay.
just, yeah. So I actually don't feel I need to wait for a clinical sign before I give the rock, because propofol works within 30 to 60 seconds. Rocuronium works within 30 to 60 seconds. So I know that rocuronium is always going to work after propofol. Yeah. And if you give a good dose, then I think you should be safe.
They'll still get the pain before the propofol is acted. And because there's no retrograde memory loss, do your patients complain of the pain in the vein afterwards?
Good question. So I think for those patients that I do want to do sequential rapid induction in that manner, I always want to make sure that I use either one in the cubital fossa or they've got a central line in. You're absolutely right. Yeah. If they have if let's say they're a difficult access and they've got one in the one at the back of the hand, what I'll often do is that I'll actually put in some local anesthetic in before, so that it will actually prevent that pain sensation. I think that that's something you learn along the way, where you've given rock and patients go, oh, that's really painful, and you go, all right, next time that's something to be aware of. Give some local anesthetic if you want to do that in a peripheral vein.
Yeah, sounds good.
All right, next one. Now I think we're going to move on to patient factors. So what have you got there for patient factors?
Yeah, so probably maybe 4 things I feel like are most important. So site of action. So, what is the muscle or the site of action? Maybe nicotinic acetylcholine receptor differences, upregulation or downregulation, access to the central compartment, and then interaction with other drugs. So if I think of site of action, really for intubation, essentially you want paralysis of the respiratory system. And so, and same for recovery. You really want, recovery of function of everything. So let's say small, rapidly contracting muscles, like, the extraocular muscles, they're affected very quickly, and they've got, generally speaking, a decent blood flow. Fast contracting fibers have a higher density of the nicotinic acetylcholine receptors, more so than slow contracting fibers, but they do reach equilibration with plasma levels of the neuromuscular junction blockers faster. So they might have more rapid onset with these fast contracting fibers, but maybe have a less intense block. So yeah, that's probably the first thing to kind of think about. In terms of like the nicotinic acetylcholine receptor differences, so you might get upregulation of the postsynaptic receptors with upper motor neuron lesions. So that might have a slower speed of onset with a non-depolarizing blocker. So imagine someone's had, a stroke or a spinal cord lesion. Suddenly you get, lots and lots of receptors. And what you'll see kind of clinically with this is you give a dose of, first of all, succinylcholine has a, massive effect. And suddenly you get the risk of hyperkalemic arrest because you've got so many of these extrajunctional receptors depolarizing, causing potassium release. But then in these patients, if you were to give neuromuscular blocking drugs, there's so many receptors to block that you have a slower speed of onset. And look, I'd say in clinical practice, I used to work at a burns hospital. You get these patients who they chew through rocuronium I'm not kidding when I said some of these severe burns patients we would do paralyzed anesthetic, general anesthetics with paralysis for. They would need about 30 to 50 milligrams of rocuronium every 15 to 30 minutes, and that's just an indication. Like that's absolutely outside the scope of normal. That's how many extrajunctional receptors they'd have. And you can just imagine how much rocuronium we went through in a long kind of 2 to 3 hour case. You can get the downregulation of the receptors. So think of myasthenia gravis. You just get this autoimmune destruction of these acetylcholine receptors. And generally speaking, you need a higher dose of succinylcholine, but you need probably less. So you need even 10% of your dose of non-depolarizing relaxants will exert its effect. So you can imagine a fast onset with that. So then the third one, access to the central compartment. So quicker onset can happen with greater blood flow to a muscle. So if you think of the diaphragm, it's a pretty high blood flow muscle. You'll get faster onset with a diaphragm than something like the adductor pollicis muscle, which is a bit more peripheral. And that said, someone who's got very vascular tissues, maybe they've got a high cardiac output state for whatever reason, then you can again logically think that you're going to have faster onset of these muscle relaxants with that. Interaction with other drugs is the last part here, and there's just so many drugs that exert an effect often it's through some kind of calcium channel inhibition or whatever it is. So volatile agents, they enhance, block antibiotics, magnesium, and also hypocalcemia states. And so it's all really calcium related. And we notice this a lot, like often with volatile patients on volatile anesthetic, they just need a lot less anesthetic to keep still than someone, say, on propofol, where you often need to give more opioids or a paralytic. I haven't really seen the significance of antibiotics, like giving gentamicin. I really haven't seen this kind of effect have any clinical significance. Magnesium, again, theoretically blocks the calcium channels, and hypocalcemia, obviously there's less calcium floating around. But the one that I've noticed clinically significantly is volatile.
Volatile, hey? Yep. There's actually a lot to unpack there. One of the things I want to talk about, which was a really interesting idea that you brought up, was the difference in muscle groups. So in terms of diaphragm, laryngeal muscles, and adductor pollicis, because I think there's a lot of confusion out there with the idea of onset versus the sensitivity to the drug, or the efficacy, if you want to call it, or the resistance actually to neuromuscular blockade with those groups of muscles. So I think you really sort of described it really nicely in terms of that the muscles which have a lot of rich blood flow, so diaphragm, laryngeal muscles, they'll actually have a faster onset. But in terms of their resistance to neuromuscular blockade, they actually have a higher resistance. So
the diaphragm has a high resistance, but that's really rich in nicotinic receptors, but the larynx doesn't have as high resistance, does it?
No. So this is where the confusion is. So the larynx actually has a high resistance. It's the pharyngeal muscles which are most sensitive. Yes. Yep. This is one of those tricky ones. So they talk about the idea that when they were measuring and there's a graph that shows this, when they were measuring the depth of neuromuscular blockade with a dose of muscle relaxant, and I think that was done with vecuronium, what it showed was that the onset occurred quicker in diaphragm and the larynx. It occurred much later in adductor pollicis, but in terms of the amount of the depth of neuromuscular blockade, you could actually get a deeper depth of neuromuscular blockade at the adductor pollicis versus the diaphragm and the larynx, which meant that they also recovered quicker as well. Now, the thing that trainees need to know, and in fact clinicians need to know, is that when you think about reversal of neuromuscular blockades, the pharyngeal muscles are the most sensitive. And so what happens is that if you just have a TOF ratio of 0.7, it's been shown that your pharyngeal muscles are still weak, because remember that your TOF ratio is done at your adductor pollicis. And what they showed was that because your pharyngeal muscles still have a degree of relaxation there, patients are still prone to aspiration, which is where that new sort of idea sort of came up probably about a decade ago, where we talked about making sure that patients were reversed to a TOF ratio more than 0.9. Because I think about 15 years ago, when I went through, 0.7 used to be where it was generally accepted. But after that study, which described the risk of aspiration due to the sensitive nature of pharyngeal muscles, we now go for 0.9.
Yeah, that's really interesting. And I really love how you mentioned those graphs. Because I think it was those graphs that mentioned that, we're measuring onset at the adductor pollicis. And so if we wait for the adductor pollicis to have its block, let's say with a short-acting drug, then potentially the diaphragm has already recovered by the time it's time it's gone. But you give a big dose of rock, that really doesn't matter. If your adductor pollicis is blocked, your diaphragm and your laryngeal muscles are definitely blocked. So it is safe. But I think they do say, because it's adductor pollicis doesn't have the fast blood flow or the high blood flow, it's not a central muscle. To measure the extraocular muscles for their twitch is probably a better indicator of the readiness for intubation.
That's right, correct. And you're right, if you give a big dose, probably doesn't matter. I think the study that this was done, I'm just getting up now, was with a 0.07 milligram per kilo dose of vecuronium. And in fact, I'm I might show it to the audience here. So you can find it in Miller's if you want to see where this study is from. It's from Anesthesiology in 1991. And you can see here that the larynx, the onset occurs quicker, but you can see that the depth of neuromuscular blockade doesn't reach the same level as it does at the adductor pollicis. You'll see different variations of this graph, so that instead of the larynx, you might see the diaphragm here as well. I've seen that different variation there. Anyway, really, really interesting.
Nice.
Now, there's only one other thing I want to talk about, which was myasthenia gravis. So that I think that it's generally accepted that with non-depolarizing muscle relaxants, they're going to have a faster onset. With depolarizing, though, if you decide, which you shouldn't, but if you do decide to use succinylmethonium in myasthenia gravis patients, they're actually a lot more resistant to that. And why is that, La?
Yeah, so because you've got less receptors to act on to depolarize, because now we're talking about an agonist rather than antagonist. I think the theory is that you just need more of it to exert an effect on depolarizing all of that muscle.
That's
so
right.
yeah, you got to use higher doses of
much higher doses. Yeah, I think they say 2 to 2.3 milligrams per kilo, like big doses, double the doses.
And the funny thing is, because you've got such weak muscles in this, that often you can just intubate on propofol and alfentanil or fentanyl. So a lot of it probably is a bit academic, that we're not necessarily using muscle relaxants for these cases of severe myasthenia gravis, where it would have a big effect.
Yeah, I think so. Well done. I think you've really covered everything that has to do with the onset of neuromuscular blockade, or the speed of onset. And I think those ideas there's a lot there, and there's a depth that you can also reach. But because there's so many ideas, it's really important to make sure that you cover the breadth, I think, of the concepts related to the onset of neuromuscular blocking agents.
And this is a nice question, because a lot of it flows on well. It's logical. Everyone knows physicochemical, pharmacokinetics, pharmacodynamics, and patient facts. Everyone knows that. Everyone knows Fick's law. And then if you just plug in the gaps, the actual new knowledge, I feel, is potency, but that's interesting. Priming principle, that's interesting. And then maybe knowing about the different, the patient stuff's probably a bit unique, upregulation, downregulation, that's different. Fast contracting versus slow contracting muscles, that's different. And, interaction with other drugs. These are probably the points of difference, I'd say, with this question, and everything else kind of flows logically from your existing knowledge.
Yep. Oh, good. And then what I thought we could do is, I've been watching a lot of, Instagram, YouTube, and on the YouTube, they got like TikTok videos. I'm not saying I'm on TikTok, but I'm learning, and they do a lot of reaction videos. So I thought what we could do now is we could do a little reaction to an answer. And I thought the answer that we could react to would be, Stuart Watson's amazing resource at Ketamine Nightmares. So for those who don't know, Stuart Watson set the exam a couple of years ago. He's created this amazing website called ketaminenightmares.com. Do check it out, where he's actually created model answers for a lot of the questions there.
Yep. So watch my face and go, I missed that. I missed that. Go on.
So look, I think that for those listening, we'll just talk about this, but you can certainly get the answer online. And I think what we'll do is we'll go through it, and I'll ask you, La, what your thoughts are with each sort of section. Okay. So here's the answer here: outline factors determining speed of onset of neuromuscular blocking agents. He's got a list here where he wants to talk about the intro, kinetics, where the dose is related to the plasma concentration, the biophasics, where the plasma concentration is going to be related to the effect site based on Fick's law, and then the dynamics, where the effect site concentration produces the effect. And these will be factors affecting sensitivity. What are your thoughts about that?
Yeah, so I guess that's not too dissimilar, because essentially my physicochemical properties is probably in the biophasics for Stuart. And then he's chucking Fick's law into that biophase, which is essentially plasma through membrane to effect sites. So yeah, I'd say the outline's probably going to be similar.
Yep. And I think I understand those ideas where we talk about the dose becoming the plasma concentration. That's due to kinetics. and again, the plasma concentration to the effect site, which is based on Fick's law, and that's to do with the biophase, and then the effect site producing the effect, and that is related to dynamics. I quite like that. I do like that.
Yeah, that's quite elegant because it flows logically. So yeah, I'll be very happy to adopt that.
Great. Now he's got an introduction. And so he's got this idea of onset definition where it's the time to 95% depression in single twitch height. And then the determinants are time for transport from site of injection to muscle, time for transfer from plasma to effect site, and effect site concentration associated with onset. What do you think about that introduction there?
Yeah, I mean, it really, so I'm assuming he doesn't start with the list.
Well, that's the
with
thing.
That intro.
Correct. So this is the challenge, I think. I think this introduction is similar to what he's trying to list out from the start. And this is probably a reproduction of, some key ideas. With that determinants, he's really listing the things that he's put up at the start. Because I think one of the challenges is you have to try to reproduce this in 10 minutes. And so I think this would be probably a repetition of concepts.
And you could easily just put in kinetics under that. Yeah, there's kinetics, biophysics, dynamics. You could just put in determinants and bundle it all together. That'd be easy enough.
I agree. So I would, for the determinants, I would put what he's listed on the intro, on his list here, under where he's put that description for determinants. I think, as much as you can for the written exam, try to be really brief. So try to avoid, sentences like this, but try to keep things short instead, like what you have up here. So what I mean that for the radio audience, what I mean by that is that instead of saying time for transport from site of injection to muscle, what I think you should write is kinetics, dose to plasma concentration. Okay. And then he's got a very similar idea to what you have written last. So kinetics. So, geniuses think alike. With kinetics, you've got factors that increase rate of plasma concentration at the muscle, and he's got administration and he's got distribution. So administration, he talks about the route, the site, the dose, priming dose, rate of injection, and distribution. He's got cardiac output, blood flow rate, and blood volume. What do you think about that? He's included some of the factors that you put in pharmacodynamics in pharmacokinetics.
Yeah,
what do you think about that?
I mean, distribution, so probably hasn't mentioned. I think I'm happy with my pharmacodynamics kind of aspect for talking about certain situations of the receptors and everything, but it probably doesn't talk about the volume distribution stuff there.
Well, he's got this here. I think this is where he hasn't probably described it as precise as you have, but I think it's a similar idea here where it goes increased blood volume, causes dilution,
I think
increases the rate of rise of plasma concentration.
The advantage of using the existing structures, right? So if every time you say kinetics, you're going to do, absorption, distribution, and you invoke things like protein binding and volume. It's like it's no extra memory. Plus, blood volume comes into the volume distribution, but so does protein binding, so does fat. So I think that you can get more out of this by using volume distribution as a title with subheadings of blood volume and protein and stuff. So I think maybe
you'd have volume of distribution here just to make sure that it's a lot more precise. Yeah,
I'd say distribution, and then in that is volume of distribution, and under volume of distribution is very many things, including blood volume. So I think you get more points. You can put more factors down if you were to say that.
Yeah. Now, the next one he talks about is the biophase. So factors increasing rate of transfer into the neuromuscular junction, which increases speed. He's evoked Fick's law here, and then he talks about increasing concentration. In fact, what he does right now is just talk about breaking down Fick's law of diffusion. So increasing the concentration gradient and increasing the diffusion coefficient. It's a lot of detail here. And what are your thoughts about trying to include this idea into your answer?
I've got to say, I love the fact that he's got numbers. Even in the previous section, he talks about this is the priming dose for atracurium, 0.05 milligrams per kilogram, wait 3 minutes, and then give a 2 times the ED95 dose and only wait for 1.5 minutes. The fact that he's got numbers there is pretty impressive. And I would love to think that I would be able to memorize that. because it's practical and you can think about it as you're doing inductions. I don't think it's so esoteric that you can't remember this stuff, because you could theoretically be thinking about it and practicing in day-to-day life. So, I expect you don't need the actual numbers, but I think it's impressive, and I think it's easy enough to learn if you can remember it for the exam.
Yep, good. And then he's got dynamics at the end. So physiology, pathology, drugs, and toxins. Now, if you look at this page, you would say this is, this would be a 10-minute answer that you could write in one page, but he's actually got more. So
more.
Yeah, I know. So not only have you got dynamics, that factors that increase ED95, you've also got factors that decrease your ED95. I quite like how he's talked about it in terms of ED95. Now he seems to have a format where he talks about the physiology, pathology, drugs, and toxins. And again, for the factors that decrease ED95, it's physiology, pathology, but then he's divided into presynaptic drugs, postsynaptic drugs, post-junctional drugs, and toxins. There's a lot here.
That's a lot here. I didn't even really think about, tetanus toxin, for example, in the context of this. That's probably, really outside of what I even learned for my exam. So, and even malignant herpes post-junctional activation, I've not even heard of that really. So, it hasn't come up clinically. It hasn't. When you got this much information, now I'm thinking, and again, this is my bias, I didn't learn that, therefore I'm thinking, was that necessary? But I do really like the fact that he's categorized this in, increase ED95 and decrease ED95. I do like that categorization. That's quite nice.
Yep. Look, there's no doubt this is a complete answer. But if I was thinking about how I would replicate this for the exam, I would probably have to edit out a lot of the mechanisms that he's written down. So because you just want to outline it, like what I would do is I would just say tetanus toxin without any sort of further expansion of that answer. And things like, when we talk about the presynaptic drug, anything that sort of decreases acetylcholine release, I would have volatile anesthetic, and probably have local anesthetic. But would I have these mechanism of actions? Probably not so much. Maybe just list the drugs rather than describe the actual mechanisms of actions, because remember that you have to try to get this all down in 10 minutes, and this is phenomenal, like the level of detail that he's written in this answer. I think that this is truly a complete answer, which actually goes into a lot of depth as well. So for those who are listening, do check this answer out on KenemineNightmares.com.
Yeah, thanks very much for watching and listening, everyone. So this is Anaesthesia Coffee Break and Adrenaline Memories, and obviously this video will go unedited onto the Adrenaline Memories site, but it'll also go up on our Coffee Break podcast and on the ABCs of Anaesthesia YouTube channel. Thanks so much for everyone to come in on their morning off to listen to us just chat about this stuff, and please share with anyone who might be interested. So see you next time. Bye-bye.